I'm Michael Weiss. I'm a neuromuscular neurologist and the head of the neuromuscular diseases division at University of Washington Medical Center. And I've been there for about 20 plus years. And I see several different kinds of neuromuscular patients, including patients with myasthenia gravis, and do a fair number of clinical treatment trials for that patient population. And since I got involved in clinical research in myasthenia gravis, I've seen several of the studies in which I've participated end up with the study drug get FDA approval, starting with the Regain study and eculizumab, which started it all off, I'd say about 8 years ago. And since that time, there's been a sort of an explosion of other drugs that have targeted not only complement, including Zilucoplan, but also FcRn inhibitors and also B-cell depleters. And then most recently CAR T cells, which is sort of on emerging therapy for myasthenia gravis. And we are actually going to be participating in the phase 3 Descartes 8 study, which the phase 2 was just reported, the MG update session that I attended by Dr. Tuan Vu. Very exciting data. And so Zilucoplan is unique because it is the only self-injectable form of immune therapy for myasthenia gravis, at least for now. And so patients don't have to have any nursing support. They don't have to come into the hospital. They inject every day. And it's been a good experience from our patients, as it was reported in the RAISE trial too. They tolerate the drug well. And they do well with the drug too. And so it gives them a lot of freedom, which I think the other drugs don't do quite so much, because patients have to have a nurse come in to administer it, or they have to go to an infusion center. And so this drug, they can take it with them on vacation. They can travel with it wherever they like, and they don't need to worry about that. So I discussed post hoc analysis of the RAISE trial, which is the phase 3 randomized controlled study looking at the effects of Zilucoplan versus placebo over 12 weeks, daily injections. And that was already published quite a couple of years ago. Of course, the drug got FDA approval. But this is post hoc analysis to answer the question as to whether the drug has an impact on all the subdomains of the MG-ADL and the QMG, whether it affects different variations in how the disease presents, because it can present with more bulbar symptoms or ocular symptoms or respiratory symptoms, and it depends on the patient. Sometimes it can be quite variable. And so the question is, does the drug influence 4 subdomains a consistent manner based on changes in the MG-ADL and the QMG, and that includes ocular, bulbar, respiratory, and limb and axial weakness in these patients, and it did just that for both the MG-ADL, which is a patient-reported outcome measure, and the QMG, which is it requires specific assessments like vital capacity measures and dynamometry. So it did it in a very consistent way, and the MG-ADL changes in the subdomains, the effects were mirrored by those for the QMGs as well. So very consistent across all the metrics. And one of the things that we need to learn, are there subpopulations of myasthenics who might do better with an FcRn inhibitor as opposed to a complement inhibitor? We need to do deeper dives into the pathogenesis of the disease, because we're just assuming that every patient is the same, because when I'm talking about acetylcholine receptor antibody positive disease, and that may not be the case. So there's some interesting work done by a neuroimmunologist at, I believe he's at Yale, Kevin O'Connor, and I had the privilege of hearing him talk recently. And what he's made an argument for is we need to identify patients who have higher affinity binding of acetylcholine receptors or antibodies to the receptor, as opposed to those patients that have more complement deposition. And we're assuming that it's equal, but he has evidence that it's not, that there is some variability in regard to the serologic profiles of these patients. And we're just don't know enough about it to be able to identify patients who are going to do better with one therapy versus another. But I think that will happen in the future. We'll learn more about specific patient identifiers. There was a lively discussion based on a talk by, and I'm trying to remember her name. I think she is junior faculty at UC San Diego. And Dr. No, I think she spoke. She was one of the investigators of a real world study to decide what patients would be eligible for any of these newer treatments that are already FDA approved, like Zilucoplan, like eculizumab or Revulisumab, or efgartigimod, and based on the eligibility requirements for the trials. And she actually indicated that looking at the specific eligibility requirements, which included MG-ADL scores at baseline, QMG scores at baseline for some of the studies, exclusionary criteria for patients on other drugs or having been on other drugs, that it would only end up being 10% of the patients in the population they studied. So then the question is, does that mean that we're not finding ways to get patients into studies who don't meet these eligibility requirements? Or I think conversely, does that mean that we only need to be treating about 10% of our patients with these novel drugs because the other ones don't need it? They respond to other treatments like prednisone or rituximab or whatever. I think there's an argument to be made for both possibilities, but you could argue that the newer drugs are for a specific subset of patients, and that we don't necessarily need to use them for every routine myasthenic patient who can potentially respond to low-dose prednisone ultimately and not need anything more than that. But she made an argument, compelling argument, that it could also be that we're just not designing our trials to maybe increase the generalizability of our inclusion criteria. And maybe we need to do that in the future.